A warm welcome to all of you who have joined us today for the webinar, Treatment of Idiopathic Inflammatory Myopathies. This topic will be presented by Marianne de Visser. Marianne de Visser is an adult neurologist and emeritus professor of neuromuscular diseases at the University of Amsterdam. For over 30 years, she led the neuromuscular group at the Academic Medical Center in Amsterdam, focusing on hereditary and acquired neuromuscular diseases such as ALS and myositis. She has authored over 400 peer-reviewed scientific publications and contributions to medical books, edited 4 books on neuromuscular diseases, holds editorial roles in several neurology journals, and held several leadership positions in national and international neurological organizations, such as the Netherlands Society of Neurology, World Muscle Society, European Academy of Neurology, World Federation of Neurology, and since 2017, she is a member of the Executive Board of the EURO-NMD. A warm welcome to you, Marianne. We are all looking forward to your presentation and are delighted that you will be sharing your extensive knowledge with us.
Thank you very much, Silke, for introducing me and also for agreeing to moderate this webinar. Silke Schluter and I have been partners since many years as members of the muscle working group within our ERN, but also as participants in a workshop on bone health. Let's see. These are my conflict of interest. I would like to start with a short introduction on classification. About 20 years ago, there was a distinction between 3 diseases: dermatomyositis, polymyositis, and inclusion body myositis. But gradually, it became clear that polymyositis was not a well-defined clinical entity, and instead other disease entities were identified, like overlap myositis. If there is no associated connective tissue, it's called non-specific myositis, immune-mediated necrotizing myopathy, and anti-synthesis syndrome. And all too often, patients who were first diagnosed as polymyositis later were found to have inclusion body myositis. Unfortunately, polymyositis as a disease entity is still recognized as such in lots of countries, and in particular in the Far East. This is a slide on the myositis landscape. You see here the 5 different disease entities with their clinical features, serological abnormalities, serological findings, the histopathology on the muscle biopsies, a CT scan of the thorax in ACEs showing ILD, and MRI, the muscle MRI in IBM. This is a overview on what we can find in the various 5 subtypes. I would like to point out that cancer is found in dermatomyositis, and IMNM can also be associated with cancer. And that brought Rohit Agrawal from the US and Alexander Oldroyd from the UK to a very nice study leading to recommendations about screening of cancer. In a Delphi procedure with lots of people from all over the world, experts from all over the world, they first identified risk factors, high, intermediate, and low risk factors. And for instance, you see here the high risk factors, IIM subtype dermatomyositis, the myositis-specific antibodies, anti-TIF1 gamma and NXP2 are a high risk factor, and as regards clinical features, elderly people, but also moderate to severe dysphagia, cutaneous necrosis are high risk factors. And based on these factors, they made a recommendation for cancer screening. If there is a high risk of myositis-related cancer, then screening should take place at the time of diagnosis, but also 1, 2, and 3 years after onset of myositis, because we know that myositis is associated with cancer 3 years prior to and 3 years after the diagnosis. The screening should consist of a basic panel and a basic panel and an enhanced screening panel, and in the follow-up, only the basic screening has to take place. And the recommendations also include that one could consider additional screening with FDG PET-CT and upper and lower GI endoscopy. And these are the recommendations if there is not a high risk factor, dependent on whether there is a moderate risk or low risk. If there's a low risk, only screening, basic screening has to take place at diagnosis and not during follow-up. And here you see the screening panels, basic screening panel here, and the enhanced screening panel. You could consider a nasal endoscopy in geographical regions like Japan or other countries from the Far East, where there is an increased risk of nasopharyngeal carcinoma. It is of utmost importance, as you know, to timely screen for the presence of cancer, because this is an important prognostic factor, and obviously the order of screening is determined by presenting signs and symptoms. There are lots of cancers which can be found when on screening. Lung, ovarian, colorectal, breast, and nasopharyngeal cancers and lymphoma are among the most common types of malignancies. It's important to realize that cancer does not appear in juvenile dermatomyositis and is not increased in IBM. All those of you who are treating patients with myositis are aware of the fact that treatment is quite a challenge. I mean, the goal is simple. With our treatment, we try to improve muscle strength and skin changes, to improve or at least suppress other extramuscular manifestations, and minimize the risk of complications or of adverse effects. But there are, as I said, quite some challenges. The pathogenesis is not completely understood. I already mentioned the classification. There is as yet not a final consensus on classification. Up till now, there are few RCTs. There's usually a lack of statistical power. After all, myositis is a very rare disease, and most treatment strategies are mostly empirical. And the outcome measures, I will talk about that later, are based on the old classification, including polymyositis. I'll start with the mechanisms. What do we know about that? Well, we do know that in dermatomyositis, there is a strong association with interference. Interference are cytokines playing a role in the immune system. And in particular, interferon type 1 has greatly facilitated the diagnosis of dermatomyositis since MXA, myxovirus resistant protein A, which is one of the type 1 interferon-induced proteins, shows sarcoplasmatic expression in muscle biopsies from dermatomyositis patients, and MXA is not found in muscle biopsies from patients with the other subtypes, and in particular anti-synthetase syndrome, which can have otherwise a muscle biopsy very similar to dermatomyositis. In addition, as I mentioned previously, there's a strong association with cancer due to what is called cross-reactivity. Antigens exposed by the tumor initiate an immune response against the tumor. And the presence of the myositis-specific antibody TIF1 gamma, but also NXP2, have been shown to indicate a particularly high malignancy risk. Anti-synthesis syndrome is found to have an interferon 2 signature. And in addition, JAW1 peptides induce the activation of innate immune cells and act as chemoattractants, and that leads to migration of immune cells into the lung and the production of specific autoantibodies directed against an amino acyl transfer RNA synthetase. In IMNM, immune-mediated necrotizing myopathy, there are two myositis-specific antibodies, SRP and HMGCR, and they play a role in the pathogenesis. And these antibodies were found to be directly linked to disease activities. And finally, inclusion body myositis, IBM. The pathogenesis is still unresolved. Some researchers suggest myodegenerative and other inflammatory mechanisms, and probably both are true. Inflammation in IBM can trigger and sustain cell stress in skeletal muscle, which leads to accumulation of unwanted proteins and irreversible muscle fiber damage. Type 2 interferon signature is increased in IBM and thus increases the expression of a marker, the major histocompatibility class 2 in IBM muscle biopsy, and that can be helpful for diagnosis. Now, the second challenge, the RCTs. There have been RCTs, some RCTs, usually small ones, in dermatomyositis. A recent IVIG trial has been published, and I will come back to that later. Rituximab has been trialed in dermatomyositis and polymyositis, and there have been several trials in IBM. Unfortunately, all turned out to be negative. The immunosuppressive medication is the mainstay of treatment, and prednisone, and you see the dosage between brackets, is the first drug that is usually administered to patients. If there has to be a fast response, one can give intravenous methylprednisolone, and we found that dexamethasone pulse therapy, also oral therapy, in cycles of 40 milligrams per day, 4 consecutive days on a monthly basis, is as good as prednisone, but associated with lesser side effects. I'll come back to the second line and third line medication, but I would like to expand a little bit on the side effects of corticosteroids. As I mentioned, we found that dexamethasone was as good as prednisone. That is done, investigated in a trial in which we gave monotherapy, either with prednisone or with dexamethasone, and we found that more than half of the cases had either treatment failure or serious side effects, necessitating discontinuation of this medication and initiation of other immunosuppressive medication. As you can see here, the patients already show some nasty side effects. This girl used to have a face like that, very slim face, and now she has a Cushing face, as you can see, with a rash. These are nasty striae, and here you see ecchymosis, all side effects of prednisone. But there are many other side effects, as you can see on this table. Very recently, an international consensus guidance for the management of glucocorticoid-related complications in neuromuscular disease was published in Muscle and Nerve. I have to say that all these authors are based in the US, so I don't know whether we can translate it to other parts of the world, but I mean, actually all the recommendations are very familiar to me. Patients who use glucocorticoid have to have multidisciplinary care. and that also includes the general practitioner. Patients should be counseled about what can be affected, and in particular with regard to the side effects before the therapy is started. Blood sugar, blood pressure has to be monitored, and that can be done door the GP, for instance. Prophylaxis against peptic ulcer disease has to be given. The patients have to be examined regularly by an ophthalmologist. Vaccinations on influenza, pneumococcal, zoster are recommended. Screening for other infectious diseases is recommended. Bone health, I will come back to that later during this presentation, should have attention. And a very important recommendation, taper slowly. These are the second line and third line medications, well-known drugs, methotrexate, azathioprine, mycophenolate Mofetil, and also IVIG is considered a second line medication. I'll come back to that later. And these are the third line drugs, although some consider rituximab as a second line drug. More than 10 years ago, a Cochrane review has been conducted. And you see here all the medications and combinations of medications. And they found that only intravenous IVIG improves muscle strength, and that etanercept, which is a TNF-alpha inhibitor, might be beneficial. For all the other medications and combinations of medication, there was not enough evidence. And they revised their review over the past few years. And I'm sure that the results, the publication will appear later this year. And they found they did not change their opinion on all these immunosuppressants, but they found that an RCT with abatacept, which blocks the interaction between T cells and antigen-presenting cells, was negative, unfortunately, and a new IVIG RCT showed improvement of skin and muscle, and I'm going to address that later. They concluded, the authors of the Cochrane database, that there is insufficient evidence from available RCTs to confirm the value of immunosuppressants in myositis. This conclusion appears to contradict the experience of many clinicians. Indeed, I mean, we all still use methotrexate, azathioprine, and the other medications you saw on the previous slide. I already mentioned the trial we conducted, and I show this slide in order to convince you, if that is necessary, what a serious disease myositis is. In our trial, we found that only 30% of the patients had a clinical remission, and 70% were chronic or had a polyphasic disease course. After 1.5 year follow-up, almost 70% still perceived disabilities, and after 3 years follow-up, nearly 40% was, according to the SF36, dependent on help from others for their activities of daily living. And these findings were quite similar to a study by another group from France. So it's quite clear that there is a search for other drugs that can alter the course of the disease. And the first that was tested was IG. Our group in Amsterdam, started a trial in which IVIG was given to treatment-naive patients as a first-line therapy. And as you can see here, 20 patients were treated. Half of the patients, only 10 patients, ended above the treatment improvement score. which was moderate improvement, a treatment improvement score of 40. And unfortunately, the other half did not achieve that result. There are two other studies which administered IVIG in here all the inflammatory myopathy patients, including dermatomyositis, IMN, and anti-synthetase syndrome patients were treated. And these two, confined themselves to immune-mediated necrotizing myopathy. Martinez Lopez from Ingrid Lundberg's group included 24 IMNM patients who had been exposed to statins. 5 patients were steroid-free and were treated for 3 months with IVIG, and the others had add-on medication, IVIG, in addition to treatments. Remission or low disease activity was achieved in nearly 90% of the patients, including the 5 who did not receive steroids, and the time to remission or CK normalization was similar in both groups. So this looks promising, but needs further investigation. And the other abstract, the other title of the study is from a study by Kosolowski from Rohit Agarwal's group. They treated mainly anti-HMGCR positive patients with IVIG, and 85% of the patients demonstrated clinically significant response, including marked reduction in daily prednisone requirements. Again, promising, but not sufficient to recommend IVIG as first-line treatment. During a workshop a couple of years ago, the recommendation, and it was a consensus meeting, was made that you should start with IVIG in IMNM within a month if steroids are not sufficiently efficacious. So in that respect, IVIG is a second-line drug. And then the trial I already alluded to by Rohit Agarwal. He treated refractory dermatomyositis patients, so patients who had been treated with all sorts of medications and had flares or relapses. As you can see, the results are really impressive. This is again on the y-axis, the treatment improvement score, here the weeks. It was a 16-week trial, and you see the significant difference between the placebo-treated and IVIG-treated patients. When in the open extension study, when the placebo-treated patients also were administered IVIG, you can see a steep increase of their improvement. So this was a great success, but we have to take into account that these patients were all refractory, so here too IVIG is second-line treatment. But maybe we have results about first-line treatment soon. Our group, and Joost Raphorst is the PI, started another trial a couple of years ago in which patients with myositis, so dermatomyositis, IMNM, and anti-synthetase syndrome, but also overlap myositis patients, were treated with IVIG in addition to steroids. And these patients are all treatment naive. He told me that they strive, well, the power was calculated at 48 patients and they only need 4 patients. So I'm sure that we will have the results at the end of this year. Rituximab is another story. It's an anti-CD20 monoclonal antibody that depletes the B lymphocytes from the blood. There has been only one RCT, a large RCT, in which 200 patients were enrolled, but the patients could be adult or juvenile dermatomyositis patients and also adult polymyositis. And already told you that there is an issue with that diagnosis. It was a randomized placebo phase trial in which they had an early arm and a late arm, and in the late arm, the patients started with rituximab 8 weeks after the early rituximab arm. They had lots of secondary endpoints. The primary endpoint was the time to DOI between the rituximab early and the rituximab late group. Unfortunately, all these endpoints, both the primary and the secondary endpoints, were not met. However, the patients all reached the predefined definition of improvement, and since then, rituximab is introduced in clinical practice. And here you see recently performed systematic review and meta-analysis on rituximab, including 26 studies. 2/3 of the patients responded to rituximab, and 45% had achieved a complete response. There is not much difference with regard to efficacy rates in the 3 subtypes. And you can also see that skin does better on rituximab as compared to muscle and lung. And the incidence of severe adverse events and infections are quite acceptable. There have also been studies with another drug, JAK inhibitors, which block interferon signaling, which is an important feature in the pathogenesis of dermatomyositis, as I mentioned. Ruxolitinib was developed for the treatment of myelofibrosis and was administered in a pilot study by Olivier Benveniste from Paris in 4 refractory patients. And as you can see here in the lower row, they did quite well on this drug. This was a proof of concept study. And Julie Park administered another JAK inhibitor, tofacitinib, in 10 patients with refractory dermatomyositis, and she found improvement in half of the patients and minimal improvement in the other half. She also performed a systematic review and found that JAK inhibitors may be a viable treatment option for dermatomyositis, also for juvenile dermatomyositis. However, randomized controlled trials are necessary to confirm these findings. Now for something completely different, Rohit Agarwal. You may have noticed that he is a very active physician and scientist. Also performed an open label study with a drug which was long known, a full sequence long-acting adrenocorticotrope hormone, ACTH, and he administered to 10 refractory dermatomyositis patients and found improvement, as you can see here, of skin involvement, and also it was possible to taper the prednisone in these patients. And the author stated that the medication was relatively safe, but if one reads the paper very carefully, 2 of the patients acquired herpes zoster, which was drug-related, and 1 of them developed disseminated herpes. The treatment is approved by the FDA and not by EMA. Unfortunately, no randomized controlled trials have been conducted for overlap myositis and for anti-synthetase syndrome. These patients are treated according to general recommendations, glucocorticoids in combination with azathioprine or MMF, mycophenolate mofetil, not with methotrexate in particular in cases of anti-synthetase syndrome with regard to the lung involvement. The cyclosporin or tacrolimus are alternative agents, and in severe disease, cyclophosphamide, rituximab, and IVIG can be considered. The last barrier to designing RCTs are outcome measures, because as I mentioned before, they are based on an old classification. You see here the publication, major clinical response in adult dermatomyositis and polymyositis. They include these outcome measures, muscle strength, as you can see, extramuscular disease activities, enzymes like CK and others, also PRO, a patient-reported outcome, the patient global activity, which is a visual VAS, and also physician global activity and physical function. Those 6 outcome measures. This gives me the opportunity to elaborate a little bit on patient-reported outcomes. They are, as the name indicates, directly reported by the patient without interpretation of the clinician or anyone else, and pertain to the patient's health, quality of life, or the functional status associated with healthcare or treatment. So they express the lived experience by the patient. A working group from OMERECT, which is an international informal organized network, and I'm one of the members of that working group, has been working for more than 10 years on patient-reported outcome measures in myositis. And I can assure you that it's a tedious job necessitating to find evidence for reliability, for responsiveness, and validity. And that takes time. Fatigue, pain, and physical function, including muscle symptoms, were identified as the most important symptoms according to the patients, and we developed outcome measures for that. These PROs are now included as outcome measures in some of the trials that are currently running. Also important here in the middle circle are lung, skin, and joint symptoms, and we just started working on these features. Let's switch gears and discuss IBM, inclusion body myositis. As I mentioned before, there have been numerous trials, and you can see this on this slide, but these have as yet not been very successful. Most recently, the arimoclomol trial was proven not to be beneficial. The status of stem cell transplant is unknown. The same holds true for follistatin, and there has been a negative trial with bimagrumab, but there have been 2 promising studies with ABC 008 and with rapamycin, sirolimus. The first one depletes highly differentiated cytotoxic T cells, and both trials are in progress. I will start with rapamycin. There has been a phase 2 trial conducted by Olivier Benveniste. I mentioned him before. He is based in Paris, in France, and he included 44 patients, 22 on rapamycin and 22 on a placebo. Rapamycin is usually administered to patients who underwent kidney transplantation. The primary endpoint was stabilization of maximum voluntary quadriceps strength. That was not met, but there were promising results as regards the 6-minute walk test, the forced facial capacity, and muscle MRI assessments. And therefore, a large worldwide phase 3 trial has started. And whether this will be successful remains to be proven. And I also have to mention that, by the way, in France, rapamycin is now prescribed to most of the IBM patients, and that is the reason why Olivier Benveniste is not involved in this phase 3 trial. Selective inhibition of cytotoxic T cell lymphocyte is, and these cells are severely, selectively reduced by the ABC008, an anti-KLRG1 antibody, without harming the other T cells. This was proven in a phase 1 study, and after that a phase 2, phase 3 study started, in which imaging with PET-CT, which made it possible to identify the CD8 T cell infiltration in skeletal muscle, and to use it as a marker. I would like to spend a few words on exercise, which is considered a medicine for myositis, according to Eliane Alexanderson. She is an expert on exercise and physio based in Sweden, in Stockholm. She did she did quite some research on this. And the evidence may not be very robust, but surveys amongst patients show that the patients highly appreciate mild to moderate intensity, non-fatiguing exercise, and also report improvement of endurance and pain. And very recently, as you can see on the right side of this slide, high intensity resistant training, RCT, was performed and led not only to improvement of muscle strength, but also endurance and quality of life. It is clear, as I mentioned before, that there is still an unmet medical need for new drugs. And fortunately, there are quite some clinical trials which are running currently with different mechanisms of action, as you can see on this slide. I'm not going to elaborate on that. What I will elaborate on is a very promising therapy. Actually, it's quite a hype, not only in the myositis community, but also for myasthenia gravis, other immune diseases like lupus, for instance, and rheumatoid arthritis, in inflammatory polyneuropathy, and that is CAR T cell therapy. And I would like to spend a few words on that. The T cells are collected from the patient, as you can see on this cartoon next. The cells are engineered to attach special protein receptors called CARs to the T cells that can then bind to the target, and in case of myositis, to the B cells. These modified T cells are then grown in large numbers, and they can be reinfused back into the patients where they can attack the B cells. One of the first publications was a 44-year-old woman who had anti-synthetase syndrome. And she had the following symptoms: myositis, arthritis, skin changes, and interstitial lung disease. And here you see that in a period of about 6 years, all sorts of medications were administered to her, and led to improvement, to relapses, again, improvement, relapses, until she underwent CAR therapy. And since then, during 4 to 5 months, there is a remission. You can also see that here on some of the graphs. The CK is down for a long time. The physician global activity has improved. The same holds true for the patient global activity. Muscle strength has improved, and the treatment improvement score is even above the major score. Here is an MRI showing resolution of all the inflammatory changes, and also her interstitial lung disease has considerably improved. There are other small case series or case reports, as you can see. A trial, the RESETS myositis trial, has started in patients with various subtypes of idiopathic inflammatory myopathies. So the results look promising, but there are only a few case reports. And we have to realize that it's an intense treatment to be performed in hospital together with the hematologists who are familiar with this kind of treatment in their lymphoma patients. There may be serious complications like ICANS, neurotoxicity, which can lead to confusion, seizures, or altered mental status, or CRS, that is a systemic inflammatory response due to large amounts of cytokines which are released, and that leads to fever, to low blood pressure, and other symptoms. Research needs to be done to determine which patients are good candidates. The refractory patients, but what is refractory? What is the definition of refractory? Because there are so many various treatment regimes across the world. Have potentially safer treatment options, also combined therapies being proactively optimized before switching and before embarking on CAR-T. Long-term outcomes are so far unknown. The FDA recommends lifelong follow-up, and there are only limited data on short-term outcomes. The question may be raised, are we moving too fast to ensure the safety of the patients? There is quite some pressure, especially from pharma, to recruit, and that might impact patient vulnerability and also vulnerable patient groups. This is a summary slide on non-pharmacological treatment in IIM, in all subtypes of myositis. There should be a multidisciplinary approach with the neurologist, internist, immunologist, but also physiotherapy, occupational therapy, and the occupational therapist has to do home assessments, speech therapy, exercise programs, fall prevention, swallowing has to be monitored, and nutritional support advices have to be given. In case of ILD, which is a feature not only in anti-synthetase syndrome, but also in a subtype of dermatomyositis, there should be attention for pulmonary rehabilitation and oxygen supplementation. We have to think of bone health. Show a few slides on that because it's extremely important. And here you see a group of people who came together during a workshop about a year ago, patients and experts. And you can see here our moderator, Silke Schlüter. And we all discussed the significance of osteoporosis and osteoporotic fractures in myositis and other neuromuscular disorders, and provided recommendations. What do we know about osteoporosis and myositis? Well, there was a systematic review on that, both in children and adults. Quite a number of articles were included, as you can see. Osteopenia was found in 7 to 75% of the patients, huge variability, and osteoporosis in 13 to 27%. Fractures, osteoporotic fractures, can be found in vertebrae and in long bones, also with a wide range, and we have to be aware of the fact that these fractures may be asymptomatic. There has been a case control study on vitamin D in adults with adults with myositis, and you can see that in almost 70% there is vitamin D deficiency, and people with myositis have a more than 13 times greater chance to have a severe vitamin D deficiency as compared to healthy controls. Here you see the risk factors of osteoporosis and fractures in myositis. Of course, there are unalterable factors. Female sex is more inclined to have osteoporosis, elderly people, etc., etc. And glucocorticoid therapy, that's what we all know. If you prescribe glucocorticoids, you also have to monitor the patient and screen them for osteoporosis and prescribe vitamin D and antipyrotic treatment. But high disease activity with immobility, with muscle weakness, can also lead to osteoporosis. And there are some environmental and behavioral factors like smoking, alcohol consumption, and obesity. And these are the recommendations with regard to prevention and treatment, multidisciplinary care, fall prevention strategies, monitoring of bone density regularly, DEXA scans, dietary intake, exercise, as I mentioned, and pharmacotherapy if there is osteoporosis. So think of bone health, that's important. And lastly, as part of the non-pharmacological treatment in myositis, comprehensive care, including advanced care planning, and especially in very severe diseases like inclusion body myositis, and those subtypes of myositis which are associated with ILD, because not only are they associated with a severe disease burden, but also the patients have a shortened life expectancy. And this is my penultimate slide with conclusions. There is no consensus yet on classification, which is based on clinical, serological, and histopathological studies. DM is associated with cancer and to a lesser extent immune-mediated necrotizing myopathy as well. Glucocorticoids are still first-line treatment, but not as sole treatment, and they have severe side effects. There is insufficient evidence for second and third line immunosuppressants, but they are widely used, and rituximab may be an exception. IVIG can be used as add-on. There is no evidence for first-line treatment. As yet, unfortunately, no remedy for inclusion body myositis, and non-pharmacological treatment should be comprehensive, including advanced care planning, in particular for IBM and myositis associated with ILD. And this is my slide in which I acknowledged first and foremost all the patients who were willing to participate in our studies. And those are the neurologists and the neuropathologist with whom I conducted all those studies. Thank you for your attention.
Thank you very much, Marianne. That was very impressive. Thank you very much for your great presentation. I think we have one question. In IMNM, how long you wait for the steroid to work before you start IVIG, especially the one with HMGCR up-related?
Yeah, we had a consensus meeting on that. So there is no robust evidence, but we discussed that, and we provided the recommendation that you have to administer steroids in high dosages during 1 month. And if that does not lead to real improvement of muscle strength, then you should start IVIG.
Okay, thank you. There aren't any other questions, not in the Q&A section and not in the chat. A new question. Oh, thank you for your fantastic talk. Do we have any information if antisynthetase-related myositis then become quiescent?
What do you mean by quiescent? After CAR T therapy?
I don't know. Myopathies, PPs. Can you explain it a little bit more?
Oh, I see here.
Hi, can you hear me?
Yeah, sure. Yeah,
Okay.
please.
Fantastic. Thank you
Great.
so much. Oh, great. Thank you so much, Marianne. It's fantastic. I'm one of the neurologists at the Cyprus Institute of Neurology and
Oh,
Genetics.
yeah.
It's lovely to be part of this talk. Thanks for a great talk. I just was wondering, my experience in inflammatory myopathy is, of course, much less than yours. So I'm just seeking your expert advice and guidance. If the antisynthetase syndromes ever switch off, if they become quiescent. I have an example of a woman in her 70s who is strongly positive for PL7. She
Yeah.
presented initially in her late 50s with proximal weakness and breathlessness, went on to develop more significant weakness proximal in the arms and legs, and interstitial lung disease. And for the past perhaps 6, 7 years, we feel that her condition has switched off. So her CKs, repeated CKs, are normal. Her EMG recently, about 18 months ago, does not show any irritable features. And on her serial MRC examinations, she doesn't really fluctuate. She was initially treated with steroids, which probably pushed her into remission. She didn't tolerate azathioprine and MMF. This was before my time. I don't know exactly why. So then she was started on IVIG, and she basically continues on IVIG maintenance therapy. Um, so my question is, we have 6, 7 years now of I think convincing clinical evidence that her disease is quiet. And but I'm a bit anxious about weaning her off the IVIG. It seems that
Yeah.
I don't know if the IVIG still holds her into quiescence, or if it's not doing anything. You see what I mean?
Yeah, I can see what it is. It's a dilemma. And does she have other medication in addition to the IVIG?
No, no, she doesn't have any other medication. She stopped the steroids,
Yeah.
thankfully,
Yeah.
because they were causing problems. She had gained a lot of weight. She has osteopenia, and she is early 70s. So we would be very apprehensive at that age, I guess,
Yeah.
with long-term
Yeah.
steroids.
I would be
Um,
reluctant as well.
yeah,
Yeah.
yeah.
How often does she get the IVIG infusions?
So she was, before me taking over her care about a year ago, she was on 2 grams per kilogram every 8 weeks.
Mhm.
But she never managed to take all of it, because she would get hyperviscosity symptoms and headaches. And
Uh-huh.
so she would, cut it short. So I thought, I have enough evidence to maybe wean her down to 1 gram per kilogram. And this is what I have her on now.
Yeah.
8 weekly, 1 gram per kilogram. But again, my question to myself and to everybody here is, is it needed? Um, is it keeping the disease at bay, or does the disease ever switch off on its own?
Well, I mean, every subtype of myositis can switch off. It's
Yeah,
a minority, but it does. On the other hand, sometimes they need a little bit of medication. I know that I had a patient with dermatomyositis, and she only used 5 milligram of prednisone daily, and she relapsed when we stopped that medication.
right. Okay, okay. I see.
So there is always, the danger of a relapse. So what you do now is very sensible. I mean, halving the dosage and perhaps then extending the periods between the infusions.
Yeah, yeah, yeah. Yeah, that's exactly how I thought about it. I discussed it with her. She completely understands it.
Ah,
She's worried about the ILD, so I got the respiratory physician to
sure,
keep a
sure.
closer eye on her spirometry.
Yeah,
And I guess we're keeping a close eye on her.
yeah. Interesting case.
Yes. Thank you so much. And I'm sorry I couldn't have my video. Hopefully I
No,
will
no, no
meet
problem.
at some point
Nice
soon.
to hear your voice.
Thank you so
Thank
much,
you.
Marianne. Thank you.
Thank you. Bye bye, my love.
Bye.
Here's one more point in the chat. Hi, Silke and Marianne. Lovely to see you both, and thank you for the nice presentation. Can you also comment on the development of more targeted and specific guidelines for treatment of different subtypes with different autoantibody profiles?
Is that by Karen Cheng?
It seems that she
Okay.
is it, yeah.
Yeah. So please, could you repeat her question on guidance on treatment in the different subtypes, right?
Yeah, can you also comment on the development of more targeted and specific guidelines for treatment of different subtypes with different autoantibody profiles?
Yeah, well, that's
That's a long
that
question.
only Karen can raise, because it's so true. I mean, it's so needed that we do studies like that, because up till now we do not offer personalized treatment, right? I mean, it's very general on all sorts of subtypes. I mean, the steroids, but also the IVIG, et cetera, et cetera. What we do know is that SRP IMNM is a very serious disease, and that is why we start quite early with additional medication in addition to steroids. But studies including a sufficient number of patients with myositis specific autoantibody has to be executed. But as I mentioned before, and Karen knows that as well, it's a very, very rare disease. So this has to be a multi-center trial, and it has to be done. But it is quite an undertaking to do that. Yeah, we need to go to personalized medicine.
Thank you. And we have another question in the Q&A section. Amazing presentation. Thank you. My question, in case of IBM, 60-year-old woman with dysphagia, do you think IVIG can help in this case?
Well, there are conflicting results. There has been a trial conducted in Germany by a German group. And I must admit that if I look at the results, and the same holds true for lots of other people who read that paper very carefully, we do not think that it's beneficial, that it will really improve dysphagia. But I know that some neurologists in Germany just give it a try and treat patients for some months, a patient with dysphagia, obviously, for some months with IVIG. So there's no robust evidence.
Thank you. As Karen answered, sorry for the long question, but this is a common question from patients all the time. Which treatment is best for them with a variety of profiles? Thank you for the answer and call to action.
Yeah, sure, absolutely. Yeah.
I do not see any other questions. Then I think we can end the webinar, and thank you, Marianne, for the great and impressive presentation. It was a pleasure to work with you in this webinar.
Thank you very much for moderating the session, Silke. Thank you.
You're welcome.
Thank you, Silke. Thank you, Marianne. Goodbye.
Goodbye.
Bye.
Bye.